to benefit from OHIP Plus because all of a sudden they were able to get access to life-saving medications without any cost through just using their OHIP card. And it was a game changer in terms of providing the kind of support needed for people, especially for young people. And anybody who's a parent in this room or listening knows that there's nothing more important for a parent than making sure that the well-being of their children. And I met so many constituents of mine. So with all due respect to Mr. Kitchen, I can share with you my personal experience being a member of provincial parliament at that time in Ontario in terms of the impact it made, and lack of it once Doug Ford's government took away that option, that choice, the suffering a lot of people are facing. So I'll go to Ms. Salas. Good to see you again. Thank you for your hard work and advocacy. Choice is coming up here often, that somehow this legislation is going to undermine choice, that somehow is going to take away the choice. I see it the opposite. I see it's actually creating choice, creating more options for people who don't have farmer care, who are uninsured or underinsured. Can you, from your perspective and all the work and research that your organization have done, tell us what your thoughts are on choice and what this bill does in terms of choice available to Canadians when it comes to access to life-saving medication, and in this case, starting with diabetes and contraceptives?
First of all, I totally agree with you on OHIP Plus. We all celebrated when it was introduced. The only downfall, we were hoping the federal government would be doing that, similar as they did with dental plan. When you use the word choice, I see it again as an equal playing field for the essential medication that are prescribed across this country. The choice will be for those who can afford more. But the equal playing field for diabetics across this country, for women across this country, will be putting them on equal footing with everyone else. The choice will be the extras.
Thank you. And you've looked at this bill fairly closely in detail. Did you find anywhere in this bill mention of private insurance, or how private insurance will disappear, or people will not have the option to access or rely on their private insurance?
No, a lot, you look at the principle under 4, it's again talking about working with Indigenous people, with the province, the territories, the stakeholders on how to implement the funding aspect. Again, as we mentioned earlier, the rare disease is specially identified there, and it continues with diabetes treatments and contraceptive. It's important to look on the simplicity of this bill that the experts will be able to work with.
And nor anywhere in this bill there's any reference to removing drugs or reducing the drugs on what's covered by private insurance.
No, there's not one union in this country that would agree on eliminating the private programs that exist everywhere.
Can I ask the same questions of Ms. Berg and Dr. Wong Rieger in terms of private insurance? In your analysis of this bill, do you see any reference to private insurance, or that private insurance will not be available for those who want to access private insurance? We'll start with Ms. Berg.
Thank you. We're actually not familiar with the private and the public plans. It's business to business, the supply chain. So I would defer to Derhan. I know she's done tons of work in that.
Great, thank you.
Yeah, so thank you very much. I think for us, the concern is to make sure that, as you know, there are essential medicines, but in many cases, there are much more personalized medicines. There are much higher level medicines that are especially for those people who have that need. So I would agree very much with Ms. Silas to say that if you need an essential medicine, you need a basic medicine, as you say with OHIP, plus, that would be available. But quite frankly, we would love to have the bill to make it so that everybody gets the medicine that they need and that nobody is actually reduced to a common medicine if in fact what they need is much more specialized. I mean, today we have private and public insurance for rare disease drugs. And I have to say the sad news is that we get over and over again physicians, patients who tell us the first question they'll be asked is, do you have private insurance? And if they don't have private insurance, they won't even get prescribed what would be the appropriate medicine because it's not going to be covered by the public plan. So if there's a plan that provides, as you say, the optimal choice for each and every patient, and they can get what is absolutely the best for them, in many cases, people end up in hospital because they don't have the right drug. So yes, we would love to have a plan that would allow everybody to get what they need regardless.
Thank you, Dr. Wong-Rieger. And thanks to all of our panelists for being with us here today. Very much appreciate your testimony and the professional manner in which you've delivered it. Colleagues, we're going to suspend now until 1:45, and we'd like you to come back right at 1:45 because we're actually going to have 5 witnesses on the next panel. So thanks again to all of you for being with us. The meeting is suspended. Second panel of witnesses for today. We have a couple of witnesses participating remotely, so I will just inform the committee that in accordance with our routine motion, all remote participants have completed the required connection tests in advance of the meeting. And for our remote participants, you will see on the bottom of your screen, you have the choice of floor, English, or French to be able to access the simultaneous translation should you require it. So without further ado, we're going to, the witnesses we have with us today, we have JDRF Canada, Jessica Diniz, President and CEO. Ms. Diniz, thank you for your patience as we work through the technical issues. We're going to start with you. We have as well, représentant l'Association québécoise des
representing the Association québécoise des pharmaciens propriétaires.
In Pharmaceutical Affairs, representing the Canadian Association of Retired Persons, Bill Van Gorder, Chief Policy Officer, appearing by video conference. On behalf of Diabetes Canada, Glenn Thibault, Executive Director, Government Affairs, Advocacy and Policy. Welcome back, Mr. Thibault. It's good to see you again. Russell Williams, Senior Vice President, Mission. And representing Smart Health Benefits Coalition, Caroline Egan, Principal Representative. So we're going to begin with opening statements in the order listed on the notice of meeting. So we're going to start with JDRF Canada. Ms. Diniz, welcome to the committee. You have the floor.
Thank you, Mr. Chair. I'm honored to be here. Good afternoon, members of the committee. My name is Jessica Diniz, and I'm the President and CEO of JDRF Canada. JDRF is the world's largest charity focused on accelerating research to cure, prevent, and treat type 1 diabetes and its complications, as well as helping to make life better every day for the people who live it. We also advocate on behalf of the 300,000 Canadians living with type 1 diabetes, representing their voice on critical issues such as national pharmacare. JDRF supports the goal of making access to medications and devices for treating and managing type 1 diabetes equitable, affordable for all Canadians. Patient choice needs to be a priority. Type 1 diabetes is a lifelong autoimmune disease in which a person's immune system destroys insulin-producing cells in the pancreas, making them dependent on daily injections of insulin to survive. I just want to underscore that. They require insulin to stay alive. So just want to make sure that is very clear. Managing diabetes represents a significant financial burden for Canadians impacted by the disease, and many treatments and devices remain out of reach for some Canadians. We thank the government for bringing diabetes and its high cost to manage the disease into focus through coverage under Bill C-64. While we align with the intention of Bill C-64 to provide fulsome, barrier-free access to treatments and devices for those living with diabetes, we'd like to raise a couple of recommendations to ensure the Bill C-64 meets the needs of all Canadians living with type 1 diabetes. First, National Pharmacare should not preclude anyone from using existing private and public insurance coverage to access insulins, whether they are listed on the national formulary or not. Bill C-64 should include a provision that clearly articulates this principle. Number two, based on consultations with healthcare providers and those living with type 1 diabetes, we'd like to see the list of insulins on the formulary be expanded to include more advanced insulins that help better treat the disease. It's a very limited list, including insulins that are rarely used and prescribed. It's important that physicians have therapeutic options to address the wide variation in individual patient responses to and tolerance of any particular drug, and that patients can access these as one insulin may work well for one person and not for another. I think this is a very important point. By expanding the choice of medicines, you increase the number of treatment options available to help eliminate side effects, reduce complications, and improve health outcomes. We also want to bring two areas of caution on how this program is implemented that we'd like to raise. Number one, changes in insurance coverage. The bill also creates a risk whereby the existence of the national formulary may motivate private insurers not to cover brand name insulins because some of the generic equivalents would now be available through the National Pharmacare program. If this happens, the consequence could be the automatic substitution of a different insulin, which can impact health outcomes. Also, another concern, number two, stakeholder engagement and consultation. This will be critical to ensuring implementation of a national pharmacare program best meets the needs of Canadians living with type 1 diabetes. JDRF is supportive of legislation that improves access to medications and devices for Canadians living with type 1 diabetes. We ask the government to provide clarity on this legislation to ensure it lives up to its intentions of equity and affordable access to medications and devices, and considers the input of various stakeholder groups that must have a voice now in how national pharmacare is rolled out. It's critical to get the implementation of this legislation right, to ensure it delivers on its promise, not only for those living with type 1 diabetes, but for all Canadians who will benefit from this program in the future. Thank you very much.
Thank you, Ms. Denise.
And now, representing the Association québécoise des pharmaciens propriétaires, we have Benoit Morin, President. Welcome to the committee. Please go ahead. Thank you very much, Mr. Chair. Parliamentarians, thank you very much for having invited me to appear here as the President of the Association québécoise des pharmaciens propriétaires. Here with me is Geneviève Pelletier, Senior Director, External and Pharmaceutical Affairs. I represent 2,050 pharmacy owners in about 1,900 community pharmacies throughout Quebec. Now, in Quebec, there is something very specific in the situation. You need to be a pharmacist in order to own a pharmacy, which means that professional independence and ethics take priority over business decisions. Patient well-being is at the very heart of our decisions and priorities. It is a unique system. In opening, I would like to say that our association is in agreement with the Canadian government's desire to improve accessibility and affordability of prescription medication for all Canadians with exhaustive coverage, but we wish to make the point that the current system in Quebec already meets the objectives of the Minister of Health. Quebec community pharmacies very clearly offer a high level of accessibility and first-line care. Pharmacy teams offer many services which go well beyond distributing and monitoring medication. And in order to offer these services, community pharmacies' financial health and funding are very important, and we are very concerned about Bill C-64 in its current form. Having a single payer system in Quebec would imperil the current community pharmacies model and would harm patients. Currently, the funding system for these pharmacies depends on professional honoraria having to do with medication distribution and monitoring. And a decrease in these honoraria could decrease pharmacies' capacity for developing added value services for patients. We've had a mixed public-private system for more than 25 years under the Régime Général d'Assurance Médicaments, or RGAM. According to the proposed single-payer public system proposed here, pharmacists' honoraria for writing or renewing scripts for diabetes or oral contraceptives would be at a single amount negotiated for the covered medication, and the impact would be significant for pharmacists because these medications are currently being used by patients, mainly by patients covered under the private component of the RGAM, so nearly 7 million services in 2023. And that's the flexibility that enables Quebec pharmacies to develop, to be in all of the regions of the province, and to offer many services to patients. This blended system enables pharmacy owners to adapt to the specific needs of the local clientele, and they can react swiftly to market competitiveness. If the situation were less flexible, the pharmacy network's financial health would be undermined, and there would be even more significant impacts in remote regions. So it's essential that we maintain this joint system in order to ensure that our pharmacies remain sustainable and effective. That's what makes access to medication constantly guaranteed and also applies to the clinical role of pharmacists as a first line of care and in looking after chronic disease. For example, over the last 12 months, more than 7 million clinical activities and first-line care activities have been performed in Quebec pharmacies. So undermining that first line of care, which is essential for the health system, would harm patients. And I will just say here that the Quebec model already meets the objectives that are set out in the national plan: accessibility, affordability, and optimal use of pharmaceutical products. There is also universal coverage for all residents. In some situations, especially for low-income individuals under the RAMQ system in Quebec, the insured person's contribution is actually zero under the current plan. This joint system in Quebec not only enables the system to meet the goals of the bill, but is actually an improvement over the public regime. So in conclusion, having a single-payer system in Quebec would be counterproductive. And in fact, it would actually lead to a decrease in the ability to meet the objectives of improving accessibility. And it would undermine our community pharmacy model in Quebec, which is grounded in communities, and in fact is the envy of other Canadian provinces. Thank you very much, Mr. Chair.
All right. Next, we're going to go to the Canadian Association of Retired Persons. Mr. Van Gorder online. Welcome to the committee. You have the floor.
Thank you very much, and thank you to the committee for allowing me to appear on behalf of the Canadian Association of Retired Persons and our 225,000 paid members across the country. We applaud the government's intention to work with the provinces and the territories to sign the agreement that would provide what is called a universal single-payer first dollar coverage. We applaud that and the plan to allocate that funding to the provinces and territories is a goal in improving the cost, the coverage of medicines for selection of drugs, diabetes drugs. However, we're very concerned about the federal government's proposal of a single public payer approach to deliver pharmacare, because we fear that this could crowd out private payers, which currently cover the majority of Canadians, including 1 in 3 seniors. CARP believes this would not be of interest to older Canadians for a number of reasons. First of all, a single public payer system would make it harder to access many of the newest and most effective treatments. Public drug plans are notoriously slow in covering new drugs and much more limited in terms of what they offer than private plans. As well, a good example is the list of the diabetes medicines. It's been mentioned before that the federal government is planning to cover. It's very limited and doesn't include the very latest treatments used by seniors with diabetes. Secondly, offloading all Canadians onto a single public plan could lead to serious disruptions. There were challenges a few years ago when Ontario moved to all youth under 25 to OHIP or OHIP Plus, the government administers plan. During that transition, many Ontario kids lost coverage for their medicines that were previously available to them under private plans. A reform of the current drug insurance system could lead to similar challenges with potentially devastating consequences for many older Canadians who rely on their medications and can't afford any disruption in their access. Third, most Canadians already have coverage for targeted diabetes and contraceptive medicines through private plans. The government's plan to invest $1.5 billion over 5 years to provide coverage to these Canadians would be a waste of public funds. There are many other areas where additional federal funding could be put to better use, including addressing the challenges of the current system, such as the high out-of-pocket expense for medications due to insufficient spending and coverage of medicines by public drug plans. This can be a major financial burden, particularly for seniors, many of whom, of course, are on fixed income. The Canadian Association of Retired Persons and our members, and we do survey our members on a regular basis, and they are telling us that they believe we could build a successful mix of public and private programs to achieve universal coverage through a targeted approach that focuses on those most in need, the uninsured, the underinsured, and those facing affordability challenges. We've already seen this model successfully implemented with the federal government funding agreement with Prince Edward Island. The province provided the provincial funding to help expand a number of drugs it covers and to reduce out-of-pocket costs for island residents. This approach, which builds on existing pharmacare programs, will likely be easier and quicker to implement than significantly reforming the current system. Canadian seniors want to see timely results that make real positive difference in how they access medicines and ultimately manage their health conditions in order to enjoy longer and better lives. Thank you for this opportunity.
Thank you very much, Mr. Van Gorder. Next, over to Diabetes Canada. Mr. Glenn Thibault, Executive Director, and Russell Williams, Senior Vice President, Mission. I'm not sure how you plan to divide your time. Okay, as parliamentarians, you know the drill. Mr. Williams, you have the floor.
Merci beaucoup. Thank you very much, Mr. Chair and members of the committee. Diabetes Canada has long advocated for the over 4 million people with diabetes for improved access to medications, devices, and services at the federal, provincial, and territorial levels. The goal of Diabetes Canada is to improve the quality of life for people living with diabetes. Diabetes Canada applauds the government's intention to include diabetes medications and devices in the initial scope of the pharmacare plan. In fact, we see this as another step in building from the diabetes framework that was tabled last year. And thank you, MP Sidhu, for your leadership in that. But there is an urgent and pressing need for those who are un- and underinsured. With broad consultation and careful implementation, this could represent a significant step towards reducing barriers. Providing comprehensive coverage and patient choice, continued improvement of care, and a robust consultation system are our 3 key recommendations. We recognize that there are significant gaps in coverage for some people living with diabetes, and our belief is that any public coverage should focus on addressing those gaps. As a first principle, we believe government should focus on the un- and underinsured individuals. But the approach to diabetes management must also be comprehensive and aligned with the Diabetes Canada's clinical practice guidelines. These guidelines are created by the country's experts and are one of the foundations of which physicians make informed decisions about patient care. Unfortunately, the formulary that was tabled along with the law by the government is not aligned with the clinical practice guidelines or the NIHB program and is limited in scope, excluding several key newer treatments while including older and outdated treatments. We have produced a comparison of the proposed formulary of the CPGs and NIHB program. This document demonstrates that for many and underinsured individuals living with diabetes in Canada, most of the commonly prescribed medications would not be covered by the proposed plan. This is why filling the gaps to focus on the and underinsurance individuals to start with is so critical. We met with the minister yesterday, and he confirmed, though, that this list will grow and will move forward in terms of greater coverage. We have to remember what we're talking about here, too. And let me underline, and I know you all feel this, but the human reality, we're talking about the most vulnerable. Our 1-800 line that is open to all Canadians, we get a number of calls regularly. Senior citizens that are choosing between rationing their drugs or going without. People not taking the right amount of their medication because they can't afford them. Recently, we were getting calls about people were concerned about their private insurance, whether they'd lose it during the transition of this law. We again were assured by the minister when we met with him yesterday that people would not be shifted off their private insurance. These are two of the fundamental questions we had. A further recommendation was an adoption of our principle of continued improvement and access. Our CPGs have shown new data continually indicates improvements to services, care, products. A pharmacare system must incorporate the principle to ensure new techniques and products which are more effective, and when they're more effective and they become available, they get incorporated into that plan. The system should actually welcome diverse approaches, creativity, including private insurance, while seeking universal coverage. Every province and territory has a distinct approach to its public formularies, and pharmacare should be no different. We already heard, but Quebec's hybrid model is an interesting example, a good example to consider. C'est un système universal, mais c'est un système mixte avec le public et le privé. We must ensure that all individuals do not lose access to drugs that they are already covered by private plans and not included in the formulary. Unfortunately, we've seen examples of that issue in the past. So therefore, we are calling for a do no harm inclusion in the law to safeguard existing access to medications and ensure persons living with diabetes can continue to access the treatments, the latest treatments and care. With these recommendations in mind, we believe that Bill 64 needs a process of evaluation and practical analysis to ensure we set up the most effective system. That is not just a debate about ideas, but it's a practical analysis for the effective system to improve access to medicines in people with diabetes. We call for a more robust and transparent consultation process in the next steps of this law with people, patients, people with lived experience, healthcare providers, drug plan managers, researchers, provinces, territories, and the Indigenous communities. We encourage parliamentarians to carefully ensure that this emerging national pharmacare delivers on its promise of improving access, and it ensures that no one gets left behind. We appreciate the opportunity to share our ideas and are certainly open to questions. Merci beaucoup.
Thank you, Mr. Williams. And finally, Smart Health Benefits Coalition is represented by Caroline Egan. Welcome to the committee, Ms. Egan. You have the floor.
Thank you to the committee for the opportunity to appear today. The Smart Health Benefits Coalition are a united advocate for smart, innovative solutions that result in timely and positive change for Canadians. Through our 7 member organizations, our on-the-ground advisors support and advise more than 65,000 plan sponsors with their employee drug plans, including over 4,800 union plans. Together, our thousands of advisors across Canada support robust benefit plans for 10 million Canadians and their families. Let me summarize our top-line perspective on pharmacare. We fully agree it is unacceptable that Canadians are currently living with little or no coverage for essential medications, stuck in the gaps between public and workplace systems. Even though 97% of Canadians have some drug coverage, nearly 1 in 5 Canadians still report having some difficulty affording out-of-pocket drug expenses. We recognize this is an affordability and access challenge that needs smart solutions. Canada can work with provinces to better solve these challenges faster and more cost-effectively by focusing net new public resources and policy energy on filling the gaps and taking a progressive approach to affordability. We believe that universal pharmacare can be done with less money spent, with better and quicker access to drugs, and with less disruption to Canadians' healthcare treatment plans if the government does this through a targeted multi-payer system rather than on its own. We believe there are a few critical considerations that need attention. A universal, single-payer, first-dollar coverage model will require taxpayers to carry the whole cost of drugs and fees. Currently, employer plans pay over $20 billion in drug claims, providing medications to Canadian families every year as a well-functioning part of our comprehensive healthcare system. When looking at the challenges facing Canadians, spending precious new healthcare dollars where workplace coverage already exists is an expensive, missed opportunity. The biggest cost pressure and pain point for any Canadian, whether you have coverage or not, lies in high-cost therapies associated with conditions such as cancer, Crohn's disease, cystic fibrosis, and many more chronic and rare health conditions that have innovative, life-changing drugs. These cost pressures are potentially devastating and deserve a higher priority within the pharmacare discussion. We've recently been very concerned to see comments by the government stating that Canadians would retain their ability to choose a new public plan or their existing workplace plan. Like other stakeholders, we are seeking clarity what universal, single-payer, first-dollar coverage means. This is important, as from our industry perspective, this term means that if the public system pays for a certain list of drugs, under the Health Canada Act, employer plans are not permitted to pay for those drugs. The result would appear to have the unintended consequence of impacting the PBO's estimates, which currently assumed continued employer coverage, resulting in savings of $4 billion per year. This is critical to resolve, and if the intent is in fact to permit Canadians to choose where they get their coverage from, then we believe this part of the bill needs to be written with clarity and no room for assumptions. Let's go over some smart solutions we're proposing. Let's use net new taxpayer funding in a way that gets coverage and cost relief to those in need. Absolutely. Require a common minimal formulary for all employer-sponsored and provincial drug plans to create predictability and a floor of coverage. Work with provinces to create a coordinated national system of rare disease and high-cost drug coverage. Update the Canada Health Act and work with provinces to include common out-of-hospital therapies, for example, cancer treatments. Now, specifically, we have proposals to strengthen the bill and framework. First, ensure coverage available to Canadians regardless of province. Without intervening in the core aims of the bill, we propose an amendment that would provide for the Minister of Health to enter into secondary negotiations with province in the event that a province were to formally reject the single-payer pharmacare. This should allow for Canada to negotiate and enter into an agreement with a province where universal, no-cost treatments are made available without the restriction of a single-payer first-dollar model. Second, examine opportunities to explore pricing reductions. Third, provide Canadians with a cost-benefit analysis prior to further steps. We propose an amendment that would ensure public accounting and cost-benefit analysis prepared and released prior to any consideration of an expanded single-payer system. Canadians deserve to know the facts and costs before governments take further steps that may irrevocably impact their ability to access and afford a wider range of medications currently provided under workplace plans. In closing, I want to thank the committee for the opportunity to appear today and happy to answer members' questions.
Thank you, Ms. Egan. And we're going to proceed now with rounds of questions, beginning with the Conservatives. Dr. Ellis for 6 minutes.
Thank you very much, Chair, and thanks everyone for being here on this important topic. Ms. Egan, I'll start with you. It's interesting. We're going to be here, and not that I mind being here with my colleagues for 15 hours to talk about this. And I guess my plea is, it's just not enough. When we see legislation like this that has the potential to impact the future of all Canadians in terms of accessibility to funding for medications, it would seem to me that this is a pittance amount of time to spend debating this and how it should be rolled out. And I wonder if you might have some comments around that and the consultations that you have had with respect to this bill.
Yeah, I would thank you for the question. I would say that indeed this is worth time well spent. We look at what a great risk it would be to make decisions around people's health care, people's drug coverage, that impact the lives and the productivity of our workforce and our seniors and those who are underserved. It's important to do this right. And with that said, this is why the Smart Health Benefits Coalition, we are advisors who work in offices, in machine shops, in union shops, in every aspect of every business in Canada to help them design their benefits package. And we see every day the pain points and what works well as Canadians navigate between the public and employer systems. So we have great insights that we would love to spend time and help us make the right path. We all agree in the destination, but the path of getting there is so important, and to have communication and clarity around this is essential.
Thank you very much, Ms. Egan, and through you, Chair. Ms. Egan, do you believe that that there are people out there who are afraid that they will lose their private coverage should this national universal single-payer system come to existence?
Absolutely. I think we can point to even recent examples with our national dental plan. I think there are some great things there in place where people had no coverage. We did fill those gaps. But there have been thousands of our advisors who have received thousands of phone calls and engaged discussion with the misperception that people can go ahead and cancel their plan and essentially replace it by the free plan, not knowing what is on that list of coverage and who is intended for. My own mother, who's turning 80 this year, got her letter, and she was completely confused and figured she would cancel her plan and have free coverage with everything included. Luckily, I'm in the business and could explain it to her. But it is a risk. It's a great risk of employers and Canadians thinking they would lose access to a longer list of medications where their health is stable on the treatment plan that they have been prescribed. And losing that access puts everything at risk. It puts the sustainability and health of our Canadians and families and our workforce and productivity at great risk.
Thank you very much. And through you, Chair, Monsieur Morin, merci beaucoup pour votre témoignage.
Thank you very much, Mr. Morin. In Quebec, are there concerns about the closures of rural pharmacies? Yes, there is great concern. We saw what happened in New Zealand. After a universal plan was put in place, about 371 pharmacies were closed. Therefore, in Quebec, we are concerned that if there is not a blended system, it will impact pharmacies significantly and lead to closures. It may also affect pharmacies' profitability. They may end up becoming centralized in urban areas rather than rural, indeed.
Il y a quelques mots techniques.
Now, there are some technical terms in what I wish to ask, and I will have to say them in English. I'm sorry.
Expanded scope of practice for pharmacists. Obviously, as you mentioned in your opening remarks, that has become an incredibly important part now of, sadly, delivering primary care in Canada because of the crumbling healthcare system, which is on the brink of collapse. I don't think that's too much to say. But perhaps, obviously in this bill, there's no mention of funding of the expanded scope of practice. But maybe on behalf of your members, you could explain to Canadians how important that is now to the delivery of care in Canada.
Oui, merci pour la question.
I'd like to thank you for the question. Now, of course, there has been different legislation in Quebec that has expanded the scope of practice for pharmacists. This has happened on at least 2 occasions. There have been 7 million clinical services over the past year, including caring for chronic illness, vaccination, and more autonomy for pharmacists. They can prescribe medication for minor conditions, for example, women's UTIs and other common ailments. We also hope that in the near future we can further expand our scope of practice. But these activities need to be funded in some way. Currently, they are funded by drug distribution. So distributing this medication means that pharmacists can carry out clinical activities. We believe it's essential to maintain that scope so we can continue playing that role. Over the last few years, we're having to do more and more with fewer and fewer resources. There's a labor shortage, yet needs are growing. We need to maintain this stability in order to continue playing a role that meets patients' expectations in Quebec.
Ms. Sidhu, please, for 6 minutes.
Thank you, Mr. Chair. Thank you, all the witnesses, for being with us. And really want to say thank you, everyone who's working on the ground, especially Diabetes Canada, JDRF. But my first question is to Mr. William. Mr. William, as we work together from many, many years, especially, framework for diabetes. Thank you, the work you are doing on the ground for the people living with the diabetes, especially in Brampton, even though I just want to acknowledge that you're also sending reps from Diabetes Canada to educate people. Thank you so much from bottom of my heart. My first question is that, on the implementation of the National Framework for Diabetes. We know that coverage of diabetes medications and devices is an essential component of the framework. Could you give a brief update to this committee on the implementation of framework, and also what recommendation can you give to this committee about the best way the Diabetic Devices Access Fund can serve patients with diabetes?
Thank you very much for the question. The framework that I referred to actually has improved access for medications and devices as one of the 6 main components. Across the country, the provinces are working on, to their own levels, implementation of the framework. I don't have time today to go into it, but I could certainly give details to the committee later on. So there's a real engagement of provincial health bodies to take the 6 pillars of the framework and implement them. So I see this as a part of the next step. Now, how we do it is still, there's a lot of questions, and I think that you talked about in terms of education. I think a lot of people around in this country don't know how the healthcare system works or how pharmaceuticals are delivered. And I think there probably is a need for greater clarity. I'd also very much encourage that, and the next phase of this law is that we take the discussions of the framework that we're doing and add concrete discussions with the provinces of how pharmacare would work within that context.
But as the minister said yesterday, the bill will not impact access to private insurance, and people with diabetes will continue to have access to the full range of medication that is provided to their current insurance plans. This will add to the existing plans and does not take away anything. What do you think about those comments from the minister?
Well, at our meeting, thank you, Mr. Chair. Thank you very much for the question. The meeting with the minister, those words were very reassuring, because when you take a look at the bill, there's a number of interpretations that we've heard about today that has gotten a great deal of concern, excitement in some areas and concern in other areas. So the clarity from the minister is important. We did also talk about the list that the government tabled. Is certainly not all-inclusive and certainly doesn't reflect the clinical practice guidelines that the Diabetes Canada creates with experts. And he assured that this is a minimum list and that we'll start to work on. We've supplied the committee members with a comparison between the clinical practice guidelines and Bill 64 list, as well as the NIHB list, which is a list of the government. So ultimately, the care and management of diabetes is not one size fits all. It's very individual focused, as you know, and that we have to make sure that we build a program that will, on one hand, not just seem that there's a certain level of cover, but it'll actually be effective cover for people with diabetes.
Thank you. And it is important to acknowledge, for the education, but also important to acknowledge the leadership of some provinces that work in implementing the national framework for diabetes, and some provinces like Quebec, you already talked about in your testimony, have a good hybrid model towards pharmacare. And let's talk about the human cost for patients. It's clear that patients just want the system that works for them. But from the meeting, we understand that we need to work with the patients during the rollout. How would you like the Government of Canada to approach the outreach component to educate patients with the diabetes on the rollout to the pharmacare program?
Thank you for the question. This is fundamental. We have to have patients at the table and being fully involved in the discussions. That hasn't happened too much at this point. And with the limited debate, which as a former politician, I'm concerned about limited debates, but that's what this decision was made. Now we have to get out in the community and we have to get concrete. We need to talk to patients, and I would say we should set up a large education program. We should start a full engagement discussion. Diabetes Canada would be pleased to help. But we should also sit down and, again, former provincial politician, we should talk to the provinces, say, here's the direction we want to go. We want to try to fix this for vulnerable Canadians. How would you do it in your province? I mentioned one in terms of Quebec, in my province that I come from, but we work with each and every province, and that's why I mentioned in my remarks we should build on the creativity and diversity of our healthcare systems across the country in both the provinces and the territories.
My next question is to JDRF. Ms. Dennis, not so long ago, you joined me in Brampton, where 1 in 5 Canadians live with diabetes for the 3rd annual Diabetes Day flag raising. It is great to see you again virtually. My question is to you. Investment into research allow innovative companies to provide new solutions and devices such as pumps, continuous glucose monitor, and other devices. The Diabetic Devices Access Fund is the key to unlock access to newest technology for diabetes patient who has diabetes. How can this fund best serve Canadians?
I'm sorry,
well, first,
Denise,
it's very nice to see you again, and thank you for the.
Could please.
Sorry. First, thank you for the question. I agree. The Special Devices Fund is critical that we get this right. Access to continuous glucose monitors for people with diabetes is so critical. It improves health outcomes and it actually reduces complications. It will reduce our long-term health care costs if we can get better access to continuous glucose monitors for Canadians. So we would propose an open engagement with the Minister's office as well as with the provinces to see how we can get more Canadians having access to CGMs. It is critical, and we will have better long-term health outcomes. Thank you.
Monsieur Blanchette-Jonca, pour 6 minutes, s'il vous plaît.
6 minutes, please. Mr. Blanchette-Jonca. I'd like to thank the witnesses for being here today. So I have a question for Mr. Morin from the Association Québécoise des pharmaciens propriétaires. From where you sit, you have an excellent understanding of the costs of certain drugs. People who are currently under a Medicare plan, will they be able to continue using it? Yesterday, the minister seemed to say yes. A credible witness from the Canadian Medicare Association, Medical Insurance Association, said that it was possible. Now, in your brief, it said that if this were to take place in Quebec, the viability of the system might be threatened. Could you please tell us what you think of that? Well, thank you for the question, Mr. Blanchet-Jonca. Yes, to think that private insurance could simply act as a complementary insurance, there's not the viability that we need to see. I'm not a specialist on insurance, but if we look at what's going on in Quebec, in the system there, I think it just wouldn't work. This is a system that functions with blanket care. Now, we know that there are also SMEs that may use collective insurance. They don't have to. They could use the public system, but they often end up with a collective system, and I think that's a good thing. I think it allows them to offer the best possible solution to their employees. I think that system should remain in place. Additionally, very often these plans offer broader coverage than the public system. In Quebec, however, we already have a public system with broad coverage. If we compare Quebec's diabetes formulary to the one in the national plan, there's a big difference in accessibility. That's what I would say. So if I'm understanding you correctly, if hypothetically we lost the private plans, or even if they were kept hypothetically, is it realistic for the government to proceed with a zero deductible? And if the same formulary could be offered? Answer, I don't believe it's realistic. Question, why? Answer, because of the cost of drugs, the increase in the cost of drugs. Choices will have to be made if exhaustive coverage is offered, if it's 100% under the public system, then the government will have to make difficult choices. Given that technology is changing quickly and new medication, very expensive medication for rare diseases and chronic diseases are coming on the market, we know that some of these new drugs are really miracle drugs, but they're very expensive. And when we're looking at the overall system, well, I can see that there might be some issues. Thank you very much. Coming back to what you mentioned earlier, you mentioned earlier how important it is to have pharmacies in remote areas. I represent dozens of communities in the Bas-Saint-Laurent, and I know that it's very important to have pharmacies. You mentioned that currently, what's proposed by the federal government could threaten community and remote pharmacies. You said that 371 pharmacies closed in New Zealand after similar legislation was passed. I'm very concerned about this. We need the services to be available locally. We want to keep people in their communities, and we also know that we have the second most aging population in Quebec in my community, and overall the population is aging. What are we to do about this demographic burden? Answer, I don't think we should put undue pressure on key stakeholders like community pharmacies. You mentioned the Bas-Saint-Laurent region. And indeed, we offered a frontline one-stop shop for so-called orphan patients. We helped them to get pharmacy services when possible. And that's a great example of a case where pharmacists can offer services. Even though these clinical services may not be appropriately remunerated in themselves, the pharmacy can still carry them out because overall they're in good financial health. But changing the system would mean that some of these remote pharmacies might have to close. Currently, there are about 8,000 drugs on the Quebec formulary. It's not perfect, but it's going pretty well. 8,000 is a lot. Might there be the risk of losing some of that coverage under the proposed federal program? Answer, if we look at Quebec's list and we compare it with the proposed ones, we can see that although it's not final, well, millions of diabetes prescriptions might be lost. A significant percentage of patients might have to change medication. Of course, we can't do that. We see that already in community pharmacies, they run out of certain drugs on a regular basis. And if you add to that dramatic coverage changes, that could be catastrophic for the health of Quebecers and Canadians. We need to make sure that the list includes Quebec's list. Even though Quebec is generous when it comes to diabetes medication, well, it's necessary for the reasons that my fellow witnesses have raised. After all, there are individual differences in how diabetes is treated. The fact that there's such variability in covered drugs, that's essential to help support people's health.
And next, Mr. Julian, please, for 6 minutes.
Merci à tout un témoin.
I'd like to thank all of our witnesses. Everything you're saying is extremely interesting. I also have a question for Mr. Morin and Madame Pelletier. Pharmacists play a key role. That's clear in the future of pharmacare. Yesterday, a large group of Quebecers, including a number of unions, Health Professionals Union, Consumers Union, and many other organizations, bringing together around 2 million Quebecers, they said the following about the situation that is currently in place in Quebec. They said that the current Quebec Medicare system does not guarantee reasonable and fair access to medication for everyone. There are many fees. And because of those fees, there can be a discouraging effect. People may skip doses or not take their medication at all because they just don't have enough money to buy them. And the increasing price of medication is placing pressure on the private system, which means that some people are losing their coverage. That is why these groups are asking parliamentarians to pass C-64. Now, you raised the matter of the lists of medications. That's something that will be up for negotiation with Quebec. We've seen that having a single-payer public plan in other countries, we've seen other cases where pharmacies did not close. Is your message today ensuring that everyone has access to the medication they need? But that we need to be extremely careful in our negotiations about how pharmacists will be affected by the universal plan? Mr. Julian, thank you for the question. First of all, before thinking about pharmacists, of course, we need to ensure that everyone has coverage. But currently, no one can pay more than $996 a year. Deductibles and copays are capped, regardless of the public or private nature of the coverage. Low-income individuals pay nothing. And so we know that for others, the limit is at $996 a year. The private system is on a yearly basis, the public on a monthly basis, but I think it's better separated it out by month because $1,000 might be too much for someone and might lead them to not take their medication. But $90 or $100 a month can be reasonable. I don't think the solution is making things free for everyone, but instead to educating people with a certain level of income that medications are critical and that they should give them the importance that they deserve, and that if they're able to pay, they should prioritize taking their medication. And then for those who can't pay and who are under the public system, then we must ensure that they have full coverage with no disincentive to taking their medication. Then we agree that the status quo is not acceptable.
You, Ms. Dinez, we had very compelling testimony yesterday from Mike Blesky, who is a young person with type 1 diabetes. He talked about what happens if he loses contracts. He talked about, well, you know, I go into my line of credit to keep paying for the medication that keeps me in health, in life. But when I asked him, well, what happens if the contracts don't come? You can't go into the line of credit. He talked very, I thought, movingly about within 24 hours, he could find himself in the hospital within days facing amputation or worse. I'd like you to tell us what happens when people can't afford to pay for their medication now? When it comes to diabetes, what are the impacts? When you can't afford to pay for medication, what happens to you?
First, thank you very much for the question and for bringing in this areas of focus. I agree. It is critical that patients have access to medications and devices they need. For type 1 diabetes, this is a matter of life or death. They don't have a choice. Think of insulin as like air. They need insulin to stay alive. So to your question, what happens to the individual when they can't afford their medications anymore? They ration. They don't take enough. That leads to worser health outcomes, more complications, and that actually costs the healthcare system more money later down the road. So I think it's important to think about the young person entering the workforce who no longer has coverage under their parents' plan, who's choosing their profession based on the benefits programs that are being offered that can cover their medications. So it's critical that Canadians living with type 1 diabetes have access to medication to control their diabetes, which eventually will prevent long-term complications.
Mr. Thibault, I'd like to ask you the same question. What are the impacts when people can't afford their medication?
Thank you for the question. Through you, Chair. Very, very similar to what our colleagues at JDRF are talking about. Someone who lives with type 2 diabetes will also have serious complications if they can't access the medications that they need. As a person who also lives with type 2 myself, I was diagnosed in 2016 when I was an elected official, and learning the process of what type of medications you need